Good morning, everyone. I am going to present this paper on buckling of intraocular lens haptic in hydrophilic and hydrophobic IOL and its effect on vision. Nothing to disclose. Phacoemulsification with implantation of intraocular lens has become a standard surgical procedure for age-related cataract. With reduction in the size of the incision, foldable IOLs are preferred nowadays. Various materials which are used for making this IOL is hydrophilic, hydrophobic acrylic, silicone, and hydrogels. Now, the biocompatibility of IOL is very important for the long-term visual outcome. It is determined by its resistance to change optical and mechanical properties due to folding and compression during injection into the anterior chamber, refractive stability of the IOL in long term, and injection through the small incision, and the prevention of posterior capsular opacification. Now, the available literature says these are all the experimental studies. The characteristics of various IOLs under the laboratory conditions, they have been determined by Lane et al. Bazukawa et al. Also studied the biomechanical and optical properties of commercially available hydrophobic foldable IOLs. But the long-term effects of the haptic of the IOL has not yet been determined. So we determined the performance of haptic of IOLs after implantation of IOL, that is hydrophilic and hydrophobic in the long term. So it was a prospective, observational, and descriptive study. It was carried out in a tertiary eye care center in central India. Duration of the study was January to December 2017. Ethical committee approval was obtained, and the study was conducted in accordance with the tenets of Declaration of Helsinki. Inclusion criteria were patients operated for age-related cataract by phacoemulsification technique with implantation of hydrophobic and hydrophilic IOL. Routine follow-up was patients who came for routine follow-up or the complaints in the operated eye were examined for visual acuity, anterior segment evaluation, refraction, and retinal examination. Exclusion criteria were anterocapsular phimosis with buckling of IOL haptics, pupil not dilating with mydriatic because we are not able to see the haptics of the IOL if the pupil is not dilated well, unable to bring the previous record because which type of IOL being implanted could not be known, operated for subluxated cataract with implantation of endocapsular ring, patients having pseudoexfoliation, retinitis pigmentosa, high myopes, posterior capsular rent, and traumatic cataract because these patients operated with this condition, they may have inherent propensity for the development of buckling of the IOL. Patient's visual acuity was taken on the Snellen's chart, spectacle number was verified on auto lens meter, and the existing refraction was checked on auto refractometer, and final refraction was noted. The position of IOL in terms of optic and haptics were noted and photographed with imaging system after dilatation of the pupil with mydriatics. Retinal examination was done by 90 diopter lens and the indirect ophthalmoscope. Statistical analysis was done by feeding various values in the Excel sheet. This shows the buckling of intraocular lens haptic along with this you can see the buckled haptic along with posterior capsular opacification which is yacked, and these are the Ashnick pulse at the edges of posterior capsular opening. This is hydrophobic IOL being implanted. You can see the buckling on the inferior side with arrow. This again hydrophobic IOL which is buckled up. Number of eyes which were examined during that period was 444 eyes with average age of 65 years. There were 87 males and 130 females. Hydrophobic IOL was implanted in 190 eyes and hydrophilic in 254 eyes. 37 eyes had buckling of IOL. The incidence of buckling of IOL which was noted in our study was 8.3%, with hydrophilic IOL 34 eyes and hydrophobic IOL 3 eyes. Forget this is hydrophobic one with 3 eyes. PCO was seen in hydrophobic IOL in 2 eyes and hydrophilic IOL in 28 eyes. Major complaint of the patient was blurring of the vision and the diminished vision. Effect of vision in hydrophobic IOL, there was no change in the refraction which was seen in hydrophobic IOL in spite of buckling of the IOL. While hydrophilic IOL, there was a change in refraction in 9 eyes. In 2 eyes, 1 eye with -1 diopter spherical and other eye with minus 0.75 spherical and cylindrical in 5 eyes. and both the spherical and cylindrical change was seen in 2 eyes. This chart shows the duration of the phacoemulsification and the presentation of the patients with buckling of the haptics. Hydrophilic IOLs, they presented with early buckling, that is 1 to 3 years of post-op patient, while hydrophobic IOL, they presented later on, that is 3 to 5 years of the implantation of IOL. For long-term visual performance of the IOL, the haptic and optical quality is important. Optic provides clarity in vision, while haptic is responsible for mechanical and rotational stability after implantation of the IOL in the back. The strength of various IOL haptics was measured by Bazookawa et al. In an experimental study by haptic compression force, assuming the capsular bag size of 10 millimeter. They found that C-loop haptic of single piece lens has high bending deformation capacity to allow IOL to adapt to all capsular sizes. Our findings are also in agreement with this, as the buckling of haptic was seen more in hydrophilic than hydrophobic IOL. So reason for this buckling, we could not guess the exact reason for this buckling, but with a hypothesized localized fibrosis in the equatorial region of the back leading to bend in the portion of haptic touching that area could be the possible reason for this buckling. Another reason could be the softness of material due to high water content. This makes the hydrophilic IOL more moldable compared to hydrophobic IOL. Buckling was seen mostly in the vertical direction because as most of the IOLs are performed by temporal clear corneal incision. So naturally the haptics are placed vertically, that is 12 to 6 o'clock position. PCO was seen more in the hydrophilic than the hydrophobic material. This is well proved fact. But the reason in these cases could be that there is a gap in the buckled haptic so that the equatorial cells, they proliferate over the posterior capsule leading to posterior capsular opacification. To find out the exact reason, we should have a UBM and the Miyake apple view of the sulcus may guide the exact causation of the buckling, but as these facilities were not available in our center, so we could not do this study. So in conclusion, buckling of the IOL haptic was more common in hydrophilic than hydrophobic IOL. It leads to change in refraction and PCO, which was commonly seen in hydrophilic IOL. It occurred early in hydrophilic than hydrophobic eyes. Thank you.
Okay. Thank you, Dr. Joshi. Did you try to correlate the findings with the preoperative, whatever was the axial length or the refractive error? Is it possible that this was occurring more in smaller eyes where maybe the capsular bag was a little smaller in size?
Yeah, this could be the possibility, but being a prospective observational study, we could not
from the records, you can go back and check what was the axial length. Maybe this is occurring in eyes with a smaller axial length where the capsular bag may be a little smaller, and that is why you are getting molding, because it's not very common to see buckling post-op. So maybe the eyes with a smaller bag or something could be one of the reasons.
Yeah.
Lesser axial length, lesser white to white maybe diameter. Okay, thank you. And next we move on to